I was discussing with sir just before the meeting. We all believe that nutrition is the cornerstone of pediatric care. In the when new subspecialties come up and new advancement in the field of curative treatment happens, if we falter in keeping up with the updating the knowledge in nutrition, and if you don't give a holistic approach to childcare, then where the standards will slip. That is what Sir was also mentioning about. So I think this series have done a lot in improving the interest as well as the knowledge for pediatricians in the field of nutrition. Now we will miss Elizabeth Madam today because Madam is out of station. Otherwise, she always attend the sessions. And I thank profusely Srinivasan sir for agreeing to come to our meeting. Sir is a very busy person, actually helping the Tamil Nadu government in policy making also. So thank you, sir. And I thank all my team who was with me for the whole year doing all this work. And I wish all the best to the session. Thank you, Priya.
Thank you, Riaz. Actually, it was Elizabeth Madam who told that Srinivasan sir would be the best person. So, Srinivasan sir, he is the expert advisor of child health, NHM Tamil Nadu government, and he was the former state nodal officer for child health. He was the member MNCU expert group of Government of India, and he has established 83 FNCUs in Tamil Nadu and 26 pediatric emergency units in Tamil Nadu, and multiple Best Doctor awards from different associations, and also Tamil Nadu Best Doctor Award. And not only he told about he has set up the nutritional rehabilitation centers in Tamil Nadu. So over to you, sir.
Thank you, madam. I think IAP Kerala, especially my good friends Ria, Dr. Priya, Dr. Sajid, Dr. Binu, and Dr. Gopi for giving the chance to talk to you people, especially in the fake end of your year. Maybe I'm always the first person, the last person is always remembered whenever you give a talk. So I'm fortunate to have the year-end talk today. So my talk is mainly, I think when many postgraduates are watching this program, how nutrition is important in a critically ill children, which is a pet topic for me. Even though I could not implement vigorously in my ICH, still I always feel how this is going to make a game changer for the outcome of the baby. So many people will be wondering when the baby is sick, they want to do intubation, they want to do ventilation, they want to give ionodrops, they want to give fluid boluses. So many things are happening. But at the same time, are we doing justice in giving some nutrition to the baby, even on the first day or second day of the illness? So that is going to be my crux of the topic. So during my topic, I will take you to NICU, I will take you to PICU, I will take you to surgical ward, I will take you to medical ward, and also some inherited problems I will be discussing. So can you put the slide, Priya?
Yes, sir.
Yeah. So this is my first slide. This is my topic of introducing nutrition, even in the PICU setup. This is what my aim. So many people will ask why you want to give nutrition to the top importance on the first day and second day of the PICU stay or the NICU stay. So I'm going to give you a small pathophysiology where you can understand how this is important. Now, can you go to the next slide, madam? Yes. Next slide, please. You can go to the next slide also. Third slide. Yeah. Third slide. So this is the pathophysiology all should understand. See, the baby is really sick. For example, he is infected or the child has got some injury. Hello? Or some no previous slide. Previous slide. Previous slide. Yeah. See, when the baby is really sick, when the jail is infected, is in sepsis or something, what is happening in the body? There are two things happen. One is the catabolic response, other one is the metabolic response. When I say catabolic response, there is glycolysis, there is protein breakdown, and there is lipolysis also. The byproducts of all these lysis, for example, the glycolysis, the glucose, is being utilized in the peripheral tissue. The protein breakdown is taken by the liver to produce more proteins. And the lipolysis is been used by the brain for energy. So this catabolic response is always there when the baby is really sick, maybe in the first 2 days or 3 days or 4 days. When the baby starts recovering, the metabolic response comes. So this is what the normal thing which is happening in the body. The next slide, please. So next slide. I think, yeah. So this is what the initial catabolic response followed by the metabolic response. The next slide, please. So in the metabolic response, you have got two phases. One is called F phase, other one is called the flow phase. What is it, F phase and flow phase? F phase is the silent phase. The child started recovering, but nothing is happening. Where the cardiac contractility will be very low, oxygen consumption will be low, enzyme activity will be low, right? But still he is recovering. That is our cases. When people got fever 3 days, the mother of the day is not being really still is fine. Then after the day becomes normal. This was F phase and flow phase. So the F phase where it very
Excuse me, sir.
next slide. This is flow phase.
Sir?
What is this flow phase? Next slide.
Sir, excuse me, sir. There is some disturbance with your voice. So you are so you have muted, sir. Srinivasan, sir?
Sir has left, madam. I think some range
I think
problem.
sir will rejoin. There may be some network problem. You can wait for a minute.
Okay.
Yeah, can you hear me, madam, now? Can you hear me
Yes,
now?
yes, sir. Yes.
Yeah. So the next one is the flow phase. During the flow phase, everything happens now. The oxygen consumption is good, cardiac contractility improves, enzymatic action improves. The child starts really recovering. See why we should understand this F phase and flow phase and the catabolic response. Whenever you don't give nutrition during the catabolism, the metabolism is very short-lived. If you want to enhance the metabolism, there should be adequate nutrition during the catabolic phase. For example, I'll give a small example for the understanding for postgraduates. When the child, two children has got a enteric fever of 3-4 days, and fifth day they are recovering. The child of enteric fever who had adequate nutrition during the febrile illness is not losing weight during the metabolic recovery. At the same time, the child who has not had any much food during the febrile illness may have a loss of weight and other things. That's what the study in adult, it is not done in children. The adult study shows that if you support adequate nutrition during the catabolic phase, the metabolic phase will be prolonged, it will be enhanced, the recovery will be faster, and the duration of stay in the ward also very low. So this is what the basics of giving nutrition during the critical period. Next slide, please. Next slide. So now what we are going to do, let me take you to NICU. What we can do in NICU. Especially in NICU, those babies below 1.5 kg and those babies below 1 kg, it is very important. If you take below 1 kg baby, the protein degradation of every below 1 kg baby per day is almost zero point 0.7 gram per kg. That means they are the persons who lose loss of weight if you don't support with adequate nutrition. That's why in the Western countries, all babies below 1 kg, day one, they will start total parenteral nutrition without potassium. But we have not reached that stage now. But some of our centers started introducing the TPN for those babies. Next slide, please. More importantly, apart from TPN, always I prefer enteral nutrition is always keep touching, madam. It will come. Keep one more touch, it will come. Yeah. Enteral nutrition is always better compared to the total parental nutrition. So there are four critical periods in the nursery. We should be very strong in our nutrition. Number one is the colostrum. See, this colostrum has got a beautiful advantage compared to any other milk. It's a God-designed milk in which the colostrum of the 28 weeks baby is more superior than the colostrum of the 38 weeks baby. That means the protein content of 28 weeks mother's colostrum is almost 4 gram compared to the 2 gram of 38-week mother. So that means it is designed naturally by the God that preterm, who is going to have a rapid growth, who may have a small surface area, and where they are succumb to the protein degradation, this colostrum is very important. So I always say this colostrum should be the first medicine for all the extreme preterm babies and VLB babies, even though they are very sick. The baby is hemodynamically stable. If there is no ischemia in the gut, even though the child has got other illness, colostrum should be given to those babies, either in the form of NG tube feeding or direct feeding, or smearing the colostrum in the lips also will help in these babies. And of course, it is going to transfer from colostrum to immature milk, then it becomes mature milk, then the full breast milk should be followed with the follow-up also. So the number one nutrition which you can practice for any babies below 1 kg or 1.5 kg in the NICU, even though the baby is very sick, colostrum has to be introduced. We know that the advantage of colostrum, it stops BPD, it reduces ROP, it reduces ventilator-associated pneumonia. No NNEC comes when you start giving colostrum. So many advantages are there for these babies. Next slide, please. Next slide. Suppose either whether the colostrum or the milk, is it enough for these babies when I start giving to this? There are some of the studies that is done by the Bergner where the human milk fortifier, whether it's a real need for all these babies. After this study, what they have found that the American Association of Pediatrics and also the Gastroenterology Association, ISPACON, they have proclaimed that all the babies below 1.5 kg, VLBW babies, should be started with human milk fortifier. But this study did not conclude that whether to start early HMIF or late HMIF, whether there is an advantage in the early or advantage in the late, the study could not give any evidence for that. But the general instruction is this colostrum has to be, this human milk should be, this human milk fortifier can be mixed, because even though we give mother's own milk or pasteurized donor's mother's milk, but there's a difference between mother's own milk and pasteurized donor milk. Even though they are good, but still, when I say the pasteurized donor milk, a lot of bioactive properties will be lost. Some of the micronutrients will be reduced. In those cases, the child may not get adequate micronutrients, adequate macronutrients. In those situations, the HMF is very important. So the general recommendation is give HMF once they reach 180 ml per kg per day. Then you can start giving HMF once the baby reaches 180 ml per day. But whether it start early or late, it leaves to the discretion of the clinician whether he can use it or not. Next slide. So that means in the NICU, this nutrition of colostrum, breast milk, and this is very important. And I always said that when the gut ischemia is there, when the baby is hemodynamically unstable, I'll be preferring to go for total parental nutrition. The latest recommendations are, previously we used to start 0.5 gram per kg of protein. Now the latest recommendation, you can go to 1.5 to 2 gram per kg of protein even on the day one of life. The babies can sustain. And of course, 6 mg per kg of glucose, 0.5 gram of fat every day, you increase by 0.5, then 3 to 5 milligrams of potassium, 2 milliequivalents of calcium, 3 to 5 milligrams sodium, 2 milliequivalents of potassium, 2 ml per kg of calcium, multivitamin, trace elements, and of course, heparin, that is 1 unit per 1 ml. If I am going to give 200 ml, I can use 200 units. And insulin, if it is needed, if there is hyperglycemia, you can give. So TPN is another good choice in the management of NICU, but it is after orogastric or orojejunal or smearing of colostrum into this one. Then finally only TPN, because there may be complications of TPN in the form of cholestasis, in the form of catheter-induced sepsis, staph epidermolysis sepsis can occur. So there are a lot of issues, some embolisms can occur. So it is always better to go for enteral nutrition compared to the parenteral nutrition. But the baby is hemodynamically unstable. It is always to go for parenteral nutrition. Next slide, please. These are all some of the trace elements I was telling. These trace elements, somebody will be asked what are the trace elements you can give. The trace elements are mainly the most important, or even though we use magnesium sulfate as trace element, the other trace element are I have put as 0.2, 1, 1, 2, 20, 100, easy to understand. Chromium of 0.2 mg per kg, iodine of 1 mg per kg, manganese of 1 mg per kg, selenium 2 mg per kg, copper 20 mg per kg, and zinc 100 mg per kg per day. But generally in the Western countries, the trace elements are available as trace element solution, where everything will be there. You can use 0.3 ml per kg in the total parental nutrition. Next slide. Next we'll do to pediatric intensive care unit, PICU. So what we can do in PICU, this is also very important, because what happens in PICU, for example, a empyema case has come, or a status epilepticus has come, or a cardiac failure has come. See, there is always a damage to the tissue. This damage to the tissues should be always repaired only by the macronutrient or micronutrient, not by ventilation or not by antibiotics or not by any other fluids. That's why PICU nutrition, MNT, that is medical nutrition therapy in a hemodynamic stable child, is very, very important. I always insist that it should be started on day one. If it is not feasible, at least day two, at least 50% of the calories and proteins should be meted out from the parenteral nutrition that will prevent catabolism, that supports metabolic needs and improves the recovery and PICU outcome also. Some of the commonly used items I can give, which I have used in the PICU, is a high energy milk, that is 100 ml of milk with 1 teaspoon sugar with half teaspoon coconut oil, gives 100 calories and 6 grams of 3 grams of protein. Then you have orange juice, 2 orange with 200 ml water with sugar can give 200 calories. Egg Philip, we have 1 egg, 150 ml milk with 2 teaspoon sugar will give 200 calories and 10.5 grams of protein. CPP Kanji is one of the research products which ICH has managed with ragi 400 milligram, wheat 350 milligram, Bengal gram 150 gram, Bengal gram 150 gram, and groundnut 100 gram with jaggery that gives 12 grams and 360 calories. Of course, your own SAT mixture can give 8 grams and 320 calories. Any of the things can be utilized in the PICU for the good outcome and recovery of the children. Next slide. So next slide, I'm going to take you to the one of the wonderful thing which has happened in the state of Tamil Nadu. That's why I put the slide as called Nutrition Wonder. I keep pressing, madam. Keep pressing. Can you put the slide, madam? Nutrition Wonder. Next slide. Yes. So this Nutrition Wonder, you can see one girl there. She's an unfortunate girl. She's around 5 years by name, Isaki Ammal. She is from Tirunelveli near Kanyakumari. She accidentally took corrosive injection and she went in for stricture esophagus. The mother suffered in Tirunelveli for 4, 5, 6, 7 months, and the baby could not drink anything. Only sips of fluid were going in. Finally, baby went in for severe malnutrition, say weight was around 6 kg at the time of admission. It has come out in the media, and many medias were circulating this. Then immediately I took a step. I arranged 108 and took the baby from Tirunelveli to brought to ICH to assess. In fact, our Honorable Health Minister gave his bungalow for the baby to stay in the MLA quarters also for 3 months. And he said, please recover the child. When the child came, you can see these photos. It's almost severely acute malnourished child with the weight of only 6 kg. And she had a case of stricture esophagus. So what we did, our surgeon said, I can operate stricture esophagus when the baby crosses 12 to 13 kg. So the minister said, keep the baby in the MLA hospital for 4 5 months, give all food, whatever is necessary. Let us see how the child is recovering. So what we did, initially the child was treated with total parental nutrition. Then the surgeon advised enteral nutrition for this month. We started with the egg fillip, we started with CPP kanji, we started with some protein powders and whatever way, and let the child gain his weight, something like that we did. To my astonishment, we can go to the next slide. The next 5 months, even I have not read any textbooks which says that so weight will gain. But this child, to my surprise, the child jumped from 6.5 kg to 13 kg in 5 months. See, you can see the previous photo of this child, and this is a photo taken after 5 months. Even the whole government got surprised. That is the day I learned that when the baby is in real need, the very good support nutrition will give you weight. The textbook may say that it may be half kg rice or 1 kg rice per month. But in this child, I have seen almost 2 kg rice for every month, and the child has reached 13 kg. That's why I put the slide as wonder in nutrition, where the textbooks cannot explain how the child exceeded our expectations. And we never thought that in 5 to 6 months, the child will be ready for corrective surgery for sixth esophagus, and the child is doing really well. This shows that a nutrition in a critically ill children, if you try really seriously, you can see the dividend, how the child is improving. Next slide. Then I will take you to the next is a surgical ward. In the surgical ward, next slide, yeah. In the surgical ward, always we have many babies going for valvulus, malrotation, NNEC, and so many surgical problems may be there. So invariably, when they come with the gangrene, what happens? Many bowels are being resected, and they may land up with short bowel syndrome. When I say short bowel syndrome, this is less than 200 centimeter of the bowel length. Next slide, please. But what is important in the short bowel syndrome? This is the child we treated. The ileocecal area is very, very, very important because ileocecal area is the area where the absorption of iron, vitamin B12, protein, carbohydrate, everything takes place really well. In fact, many surgeons used to say that always safeguard the ileocecal region, even if you lose other intestines, because that is the one area is very important for absorption. And somebody will say that if the ileocecal is lost, what will happen to the child? Maybe the duodenum and the jejunum may stop taking the action of the ileocecal. So this is what natural designs for all these children. So when we go for this kind of children with short bowel syndrome, what sort of dietary management plan in this child? Maybe the initial 2 to 3 days for stabilization, you go for total parental nutrition. Then you really go for some of the cardinal principles of enteral nutrition. Next slide, please. Next slide. How your food should be there for short bowel syndrome, especially in a child. Number one, this food should be lactose free. It should be lactose free. Number two, the protein which we are going to use as macronutrient should be protein hydrolysate for easy and prolonged absorption. Number three, sugar. Always we say that simple sugar is good for SAM. But here in short bowel syndrome, you have to go for complex sugars rather than simple sugars because complex sugars takes time and very slowly gets absorbed, and this should be practiced. And number four, to our surprise, we always say that MCT oil we prescribe to each and every child. But in a surgical case where the short bowel syndrome I see, it is always better to go for long chain fatty acid rather than medium chain fatty acid because studies have proven that long chain fatty acids has got a very good tropic effect. So this child we have treated with this phenomenon. In fact, one of the protein hydrolyses I can say available in the market is Proteinex. You can see the Proteinex powder, which contains almost 100 grams, gives 25 grams of protein, very high protein. And we have practiced with this in this child of short bowel syndrome, and the child came up really nicely well. Next, I will take to the medical ward. Next slide, madam. Next slide. Medical ward. So what happens in medical ward? Here is an interesting case which I have dealt, a case of obesity. This child is called Taranya. She's from Vellore, 6 years, known case of obesity and hypothyroidism. Next slide, please. She got admitted in my ward with the following complaints. Number one, cyanosis during sleep. The child becomes cyanosis during sleep. There is exertional dyspnea for the past 3 years, excessive weight gain for the past 3 years, especially the child has gone for 33 kg. Then snoring is there. The child on examination had enlarged tonsils and enlarged adenoid. And our polysomnograph, which has been done in our pulmonology department, where the apnea, hypopnea index is more than 1.5. That means she is a prone case for sleep apnea syndrome. And echocardiogram showed severe pulmonary hypertension. So this is the very clear clinical picture for this child. So when this child came to me, then the cardiologist said, PhD, you can do a supportive management. I decided to go for two important type of therapy and bring down the weight of the baby so that all symptoms will go away. So the next slide, please. So what I did, initial period, I started practicing traffic signal diet. Traffic signal diet. So what is this traffic signal diet? This traffic signal diet is the most important one for obesity, in which you can see the green, the yellow, the orange, and the red. The green means the child can take anything, and how many amount you want, you can take it. It may be in the form of vegetables and fruits. Orange, weight. You can take what is the prescribed food daily you are taking, take it with caution. Don't overeat, something like that. Red, some of the oily preparations, non-vegetarian items, everything should be avoided. This is what traffic signal diet. Whenever the obesity child comes, don't go into the diet restriction immediately, because the obese children should have their commitment to reduce weight. A mother or parent or a pediatrician cannot reduce the weight of the baby unless and otherwise the child has his own ambition of reducing the weight. So to get a commitment from the baby, what I do always, the first initial 10-15 days, I practice traffic signal diet and ask the come back after 15 days whether the child is following the traffic signal diet. The child follows it, I think he's a good candidate for next nutrition therapy that is called PSMF diet, that is protein sparing modified fasting diet. What is this protein sparing modified fasting diet? See, always when I talk about this diet, you should remember 4 2s. What are the 4 2s? Number one, 2 hours of outdoor playing. Number two, 2 hours of TV watching. Number three, the child should have 2 grams per kg of protein. Number three, then child should have 2 liters of water. So 2 liters of water, 2 hours of outdoor playing, 2 hours of TV watching, and 2 grams per kg of protein. This is the first one we should introduce in this child. Then we should go for a strict dietary control in this child. When I say strict dietary control, two things, intensive phase and stabilization phase. In the intensive phase, you restrict the calorie to 800 per day, irrespective of the weight for this child. So plenty of vegetables and others are given, but calorie we saw to that is not going beyond 800 to 900 calories. This should be practiced for minimum 1 to 3 months. When you practice this, practice all the 4 2s and 800 to 900 calories per day, you expect a 10% weight loss in this baby. From 33 kg, the baby come down to 29 kg. This is what happened in my ward. Then you can go for stabilization phase, where you can increase the calorie. You cannot go on decreasing the calorie from 800, 600, 500, something like that. Once you give 800 to 900, then you can go back to 1200 calories, stabilize the child with 1200 calories. So this we did in this Taranya child, and you can see what is the improvement, expected outcome you can see. For our surprise, after 1 month of stay, or 1.5 months of stay, she lost around 4 to 5 kg from 33 to 28. When I did the echo, the pulmonary hypertension, which was very severe, has gone down to mild, and there was no sleep apnea, and the polysomnograph also has come down below 1.5. So this is a very clear case how a nutrition plays an important role, especially in a obese child. You used to have sleep apnea, you used to have this one pulmonary hypertension, but plainly with the nutrition, by giving nutrition, when the weight is coming down from 33 to 28, the PhD has come to mild, and the hypopnea index AHI has come down below 1.5 and gave an excellent result. Next, I will take you to one more interesting case. This is called diabetic ketoacidosis. This diabetic ketoacidosis is the one most of the pediatric intensivists, they are very interested in telling about the correct dose of insulin, how insulin should be practiced. And the mother comes to the doctor and asks, what are the food I can give? Many pediatricians say, don't give this, don't give this, don't give this, don't give this. But unfortunate that being a growing child, you cannot curtail all this food for these children. So what I practice, next slide, is called DANE concept, DANE concept. What is this DANE concept? DANE concept means dose adjusted against normal eating. That means you make the child to eat normally and you adjust the insulin dose according to the eating. So I give 3-4 steps to my postgraduates. When a diabetes child comes to you, what are the things you can do? Point number 1, calculate the required protein and calorie for the child. For example, this child is a 6 kg. She requires 1,500 calories as per the holiday and cigar formula and 1.5 to 2 gram of protein. So expecting around 24 grams of protein. Point number 2, divide the calories and protein into 6 small meals, frequent meals. And this meal should be more or less equal. For example, 1,500 calories, you divide into 250, 250, 250. You may not be 250, but 300, 200, not 600, 200, something like that. So the turbulence of sugar will not be there if you maintain the 6 feed in a normal manner without any variations from one feed to the another feed. That is point number 2. Then point number 3, there are 2 important things everybody should understand. One is called carbohydrate exchange. Number 2 is called carbohydrate counting. What is this carbohydrate exchange? See, generally what we say, you always say take chapati for diabetes. That's not a good advice actually. Suppose I go and live in Punjab, I say take idli, not chapati, because it differs from area to area. In fact, idli, chapati, dosa, not much variation in the protein and calories in these things. So what we should do, practice in these children, when you plan this, you divide the calories and protein equally and plan what food you are going to give. Then, next point, suppose the child is fed up with idli, then you can replace with dosa. For example, you are giving 2 idli for 4 grams. Then you can give 1 dosa or 1 chapati. You equally see that the 4 grams and the calories are not exceeded. You reduce the number, but you can change the diet. This is what we call carbohydrate exchange. That means you can exchange the carbohydrates in any forms for the child, what the child likes. You can give upma, you can give pongal, you can give idli, you can give dosa, but see to that the amount is reduced or increased and you are not altering your protein and calorie during this one. So once you calculate, next point I want to tell you, all should understand what is carbohydrate counting. What is carbohydrate counting? See, there is carbohydrate counting means how much carbohydrate is there when I take this kind of fruit, which is 100 gram, something like that. Then what you should do, you have to put the weight of the idli in the weighing scale and see whether I'm giving 100 gram or 200 gram, something like that. Because all rice material, wheat, ragi, or any other this one, for 100 gram, the carbohydrate count is around 15. And for all pulses, the carbohydrate count is 12. For all vegetables and fruits, the carbohydrate count is 5. So just remember these 3. 15 for rice and other things, 12 for the cereals, pulses and other things, and 5 for the vegetables. So once you know, then you know how much insulin you can give. Go to the next slide. This is called basal bolus regimen. So here I'm going to show you an example. For example, for this child, I'm going to give 2 idli and 200 ml milk. This is what my morning breakfast. 2 idli measured 200 gram. That means the carbohydrate count is 15 plus 15, 30. And I'm going to give milk. 100 ml milk is 12 gram carbohydrate count. That means 100, 24. That means 30 plus 24. This child, by consuming 2 idli and 200 ml of milk, takes around 54 grams of carbohydrate. That means you take 1/10 of this 54, that is 5 or 6. That is going to be the insulin. That is going to be the insulin. So that means you calculate, you decide the food, plan the food, measure the food, calculate the carbohydrate count of the food, then calculate the insulin. Then you give insulin at 7 a.m., 6 units of insulin. After 30 minutes, you give idli and 200 ml milk and check for postprandial blood sugar. You will be maintaining a beautiful blood sugar. Similarly, in the afternoon, one more example, I put that rice 200 gram, vegetable 100 gram, sambar 50 ml. Rice 200, again 15 plus 15, 30. Vegetable 100 is 5. Sambar, which contains a little bit of vegetable, is around 2, 37. That means 1/10 of 37 is 4 units rapid insulin. So this is the way you can control the diabetes in these children. That means the time has come. It's all Western style. It's called Dane concept. That is dose adjusted against normal eating. That means allow the child to eat. See, this child has to grow. I cannot control my food in this child. Of course, don't give sweets or payasam or laddu or something. But regular nutrition should be practiced. And calculate the nutrition, spread the nutrition equally, calculate the carbohydrate count, calculate the insulin. Then you know how much insulin I'm going to give. This will counter the carbohydrate count the child will have by increasing the food. So diabetes can be managed very easily in children, and never restrict the children. Don't eat that, don't eat something like that. Allow the child to eat more vegetables, allow the child to eat cereals and pulses in a minimum amount, calculate the carbohydrate count, use the insulin, and control the diabetes so that the carbohydrate which is increasing will be controlled by the insulin, and the protein which I am giving in the form of food will make the child to grow. You can see in many diabetic children, since this is not happening, most of the diabetic children are very puny, very thin, they are not well grown. So once you want a growth of the child, adequate nutrition, what is recommended should be given, and insulin should be calculated based on the carbohydrate count. Next, I will take you to one more interesting case. Next slide, please. It is a case of what is called A beta lipoproteinemia. So this is a child which came to my nutrition OP when I was in charge. So this is some innovations we did. This is a 1-month-old child who came with history of steatoria from day 6 of life with vomiting, oily stools, not at all gaining weight from the birth. Our investigation, next slide please. Our investigation showed LDL is only 2, HDL is 34, triglycerides 9, VLDL is 2, and stool contains 8 to 10 fat globules. On the smear, we had 40% acanthocytes. Duodenal biopsy showed enterocytes showing lipid vacuolization. So we made a diagnosis of A beta lipoproteinemia, which is nothing but the deficiency of microsomal triglyceride transfer protein deficiency that leads to poor absorption of fat, that leads to fat malabsorption, that leads to steatoria in this child and not gaining weight. So I don't know what to do in this child. There's no specific management. If you read the textbooks, they say give adequate supportive measures. That's what the textbook says. So what I did, I want to avoid the fat in this child. So for innovation, we practice along after discussing it by PG. I told him, let us do away from this normal breastfeeding. Normal breastfeeding, we encourage the mother to give hind milk. Here, what I told the mother, don't give hind milk. So I told the mother, make the baby to suck at your breast for 5 to 6 minutes in one breast. Change over to the another breast. Keep doing that. Don't give hind milk. Let us see what happens. To my surprise, and I supported the child with vitamin A, D, E, K, and MCT oil and avoiding triglyceride. To my surprise, you can see the next slide. Next slide, please. Next slide, please. Next slide. You can see the what? Next slide. I think we're not moving. Next slide. You press up on the slide. Next slide. Yeah, it's moving. Yeah. Yes. Yes. So this is the absolute result I got and got surprised. You can see admission, the child was length is 50 centimeter. After 15 days, it's 56 centimeter. Weight is 2.7, become 3.185. It becomes 34, it becomes 36. And the abdominal guts is 37, reduced to 34. And stool 8 to 10 fat globules has become 2 to 3 fat globules. So I was wondering with my postgraduates that you can make innovations in the nutrition. Not necessarily you can have a copybook straight from the textbook. Think about the disease. What is the pathology? What is the physiology? You act accordingly, the child can improve. And this child was told to avoid fat and slowly the child gained weight. This is one of the success story we had about this A beta lipoproteinemia. Next child. This is another child. Next slide, please. Another child who came with phenylketonuria to our clinic. So you always know that. Next slide, madam. Keep pressing, madam. One more press. Yes. Phenylketonuria. Always phenylketonuria are two types. One is the classical, other one is the atypical. Our idea is to have phenylaniline. Previous slide. Previous one. You have gone to the last slide. Previous one. Previous one. Previous slide, madam. Next to this. Next to this. See, in phenylketonuria, no, next, following this, next to phenylketonuria. This is the A beta lipoprotein slide. You put the phenylketonuria slide. Next one. Yes, then next one. Keep pressing. Stop with that. See, in phenylketonuria, there are two types of men. No, madam, you got the next. Put the previous one for the benefit of viewers. You have got two types of phenylketonuria. Our idea is to have phenylalanine at the level of 400. Madam, you've gone far. You have to go back. Anyway, before this slide, madam, stop with that. Go to the next. No, you're going. Yes, next. No, you are going back. No, madam, you are going back. Anyway, I'll tell you my theory here. See, the first 6 months is the challenging one. The next 6 months also is challenging one. You know, breast milk contains phenylalanine. I have to restrict the breast milk. At the same time, I have to give the breast milk. So what I did, you measure the phenylalanine in this child. The idea the textbook gives was for 400 to 800 maintenance, demand feed. When the child asks, give breast milk, don't go on give breast milk. When it is 400 to 800. When it is 1,200 to 2,000, you have to skip the breastfeeding for 2 days. If it is more than 2,000, skip the breastfeeding for 3 days. So this is what I did. At the same time, from one pristine one of the company, I received a phenylketonuria of a food product also, alternative, which is called LPFS, low phenylalanine food supplement, or PHFS, protein hydrolysate food supplement. Next slide, madam. Next slide. After this, next slide. Protein hydrolysate food supplement. Here we can use, yes, one more press, madam. One more pressing. One more. You can keep pressing. Stop. So first 6, no, madam, you've gone away. First 6 months you give with breast milk, restricted breast milk. As long as I'm maintaining 400 to 800, I'll give breast milk on demand. When it go to 800 to 2,200, I'll skip for 2 days. When you go below 1,200, skip for 3 days. But what will you do when you are skipping? So you have to substitute with the protein hydrolysate food supplement or low phenylalanine protein supplement. Now meta nutrition PKU is available that you can practice. Okay, so this you can do in the first 6 months. Not necessary that phenylketonuria baby should die. So once you maintain in the first 6 months by keeping on measuring the phenylalanine every month and adjusting the food within in between the breast milk and the LPFS, then after 6 months you can go start our own food. I will give you some of the directions now. What are all the foods which contain 50 milligram of phenylalanine? Number 1, milk. 50 ml milk contain 50 milligram. 75 gram of potato, 50 milligram. 54 milligram of rice, 50 milligram. 25 milligram of wheat, 50 milligram. Cornflakes, 50 milligram, 50 milligram. Fruits and vegetables have very low phenylalanine. That means you can plan the food in such a way that the fruits and vegetables should be the dominant part, and you can give milk, you can give them. One of the biggest surprise to me is more the potato, less the phenylalanine. Less the rice, less the milk, and more the phenylalanine. So you have to walk in a rope where you plan for 400 to 600 phenylalanine per day. Calculate the food accordingly. Suppose I give 100 ml milk, I am going to give 100 phenylalanine. So morning is over. In the afternoon, I am going to give, say, rice. 100 gram, I give 100. So you divide the 600 into 150, 150, 150, 150 into 4 and start giving the feeding. You won't be exceeding the 800 milligram phenylalanine. In those situations, the child may not go for a problem. You know the problems are delayed motor milestone, convulsions, hepatosplenomegaly. So phenylalanine babies also can be easily cured best by the nutrition, provided we apply our mind how much phenylalanine should be given to the child, then you can practice. Of course, the other IEM like MSUD, propionic acidemia, methylmalonic acidemia, urea cycle disorder, fatty acid disorder. I think so many food products has come. In fact, all are going to be with either carnitine or hydroxy. We are going to a cocktail therapy along with the restriction of the consign accumulated products. Then you can give meta nutrition is available for practicing. So I end my talk with this and saying this that nutrition is the, in fact, number one therapy even in the PICU, especially for those babies who had damage to the any of the system. It may be in the meninges, it may be in the lung, it may be in the cardiac system, it may be in the intestine, where my antibiotics, my inotropes, my ventilation strategies are not going to save the babies. The nutrition is the one which is going to do the repair for the damage which has occurred. It's a high time that all our intensivists who are available in our country should think of starting nutrition in the pediatric intensive care unit, in the newborn intensive care unit, from the day one of life. Day one of life in NICU, it should be the colostrum. Day 3, day 4, mother's milk, if needed, HMF. And for PICU, I think high energy milk, orange juice, CPP kanji, that is pulse and cereal mixture. All this should be tried, and you will see the outcome, the recovery, the stay of the baby in the PICU will be very short. And one day we'll be seeing our mortality goes to very low level because of the nutrition. That's why I say nutrition in a critically ill children is very important. Thank you for patient listening. And I end the talk by saying this, that thank you to all.
Thank you very much, sir, for that very illustrious presentation with so many case scenarios. And our wonder kid was very nice.
Thank you, madam. Thank you, madam.
Now the discussion is open.
Priya, Asha madam is in the
Queries?
group. We can invite Asha madam for her comments. Asha Bangappa madam.
Asha madam?
I think the Vasisthar has come. Madam, Guru
Asha
has come.
madam, please.
Parallel to Sir and his expertise, mnemonics and terminologies like 2 hours of screen time, 2 hours of outdoor activity. Excellent, Sir. It was too good.
Thank you, madam. Thank you, madam. Thank you, madam. It's all real-time experience with my postgraduate, madam.
Especially
Thank you.
Madras and ICH, Sir, Institute of Child Health.
Yeah.
Father
Yes,
often would
madam.
hear when Balagopal Raju and Bhaskar
Yeah.
Shankar,
Yes, madam.
what is the Shankar
Yes,
Narayan were there?
Shankar
And
Narayanan, Bhaskar Raju. Yeah.
Raju, and based on the Institute of Child Health, he established Indira Gandhi Institute of Child Health. Madras and
Yes,
ICH second home, and Ponnamalai High Road BRS Hospital. These are all
madam.
very pleasant memories, sir. I never miss your sessions wherever it is. Thank you very much, sir.
Thank you, madam. Thank you, madam. It's a proud moment for me, like Asha, madam, and others are giving a good comments on me. Thank you, madam. Thank you.
Interesting. Any queries?
Dr. Sajida actually presented very well about feeding babies with neurodevelopmental difficulties in ICU and all.
Yes.
In one of our
Yes,
sessions.
sir. Yes.
Dr. Sajida,
Yes,
do you want to add something or make any comment?
Right, sir. Thank you, sir. Actually, Srinivasan's class was very. This is the first time I'm hearing his class, but I think it's a big eye opener. Very, very big eye opener for us. And it is so. It was so interesting to know the difference when we start the like when he has shown his cases, and it is really wonderful. And I think I have learned the most from this class. Thank you so much, sir.
Thank you, madam. Thank you.
Parvati, madam?
Excellent talks, sir. We can all practice this in our day-to-day practice. Thank you, sir.
Thank you, madam.
Thank you so
Thank you,
much,
madam.
sir. In Malayalam, we call it Kalashi
Thank you, madam. Malayalam.
Yes.
Sir will understand that.
Yes, I understand. I understand. In fact, my daughter speaks very well. My daughter speaks very well Malayalam.
Okay.
So we have our state conference 29th and 30th.
Where, madam?
Riyas, please invite, sir.
Yes, sir. Yes, madam. I'm free. I will definitely be there, madam. Yes, madam. I'll be there, madam.
Sir,
Thank you,
actually,
thank you, madam.
Shingaravelu sir is coming Dr. Jalil Ahmad sir is coming.
I will accompany them. I will accompany them. Yeah, I will accompany them.
Yes, sir.
Right,
Thank you,
sir.
sir.
Right, sir. Right, sir.
Dr.
Thank you, sir. Thank you, sir.
Sindhu. Dr. Sindhu is our incoming president of the IVCF chapter.
Hi. Yes. And for you, I think I have not attended the national IOCF, but I came to know now that I have become an executive member of South Zone. Let us all work
Yeah.
together to lift IOCF and to a great level, sir.
Okay.
Let IAP also think that IOCF is not a small branch; it should be a really big branch. I think we should prove to the IAP
Of course.
that IOCF should be stronger.
Yes, yes, yes.
And
Thank you.
I can see, especially from Kerala, so many stalwarts are coming up for IACF compared to Tamil Nadu, sir. I think Kerala, I think many people are interested in nutrition. And so I think it's good. Let us improve our IACF, this one from South India also, madam.
Sir, very good talk, sir. Giving this milk for these children with the beta lipoproteinemia, and this can be applied to the usually we
Just
consider
stop.
what to do. The familial
Madam, it is not in
hypertriglyceridemia.
textbook. It is not in textbook.
Yeah. So practical experience is very important. We will always remember. Can we try it for familial triglyceridemia? Sometimes we used to get hyperlipemic
No,
serum.
madam. No, madam. This is the one. No, madam. Yes, madam. Yes, madam.
Sajida, if there are, we can wind it. Sajida,
Okay.
vote of thanks.
So this is our last session of Nutrilent series. It was a great journey for all of us, a great learning experience, and I think the best classes were the first and the last. First was by Elizabeth Madam, and the second, the last class also very interesting and very new concepts we have learned today. And I thank the faculty, Dr. Srinivas sir, from the bottom of my heart, and Priya madam, whose idea, whose signature. This Nutrient series is her brainchild, and I also thank our Riya sir, our president, and our secretary Gobi Mohan sir for giving us a wonderful chance and a platform to learn to do this Nutrient series. And I thank all the members who have attended, all the participants who have attended, and thank you all.
Thank you, madam. Thank you.
you.
Thank you, Riyaz.
Good night, sir.
Thank you,
Good
Dr.
night, sir.
Priya.
Good night.
Thank
Good night.
you.
Good night, sir.
Good night, sir. Good night, sir. Thank you.